ago, John?
Yep. Oh, perfect. So I appreciate you being on time. We're going to talk today about the medical management of sarcomas, more specifically soft tissue sarcomas. I'm talking with Ivy, what she conveyed to me is next year I'll actually be able to give a lecture both on soft tissue and then a separate lecture on bone sarcomas. It's too hard to be able to compress it all and then include GIST as well. So I'm going to try and keep it streamlined to talk about what you're most likely to see in clinic. It may not be what's most likely going to be on the boards, but I'll try and point out some things as we go. So, in keeping with here's your first question. 57-year-old man with a large, high-grade, undifferentiated sarcoma of his right arm. As per our conversation a couple of weeks ago, he receives preoperative radiation therapy followed by surgical resection. So which of the following is true regarding these statements below? Adjuvant chemotherapy consistently improves relapse-free survival. Adjuvant chemotherapy improves overall survival. Risk is greatest in the first 6 months. Surveillance should be performed annually for 5 years. None of the above. What are some of your initial thoughts? A, C, D, or E? I heard one C. Anyone else? C. Second question, pazopanib, also known as Votrient, was approved in April of 2012 for the treatment of advanced soft tissue sarcomas. This is actually after treatment with at least one prior therapy. The efficacy of pazopanib has been demonstrated in all of the following except which? Okay. Then the third question is a 35-year-old with metastatic uterine leiomyosarcoma, low burden disease, asymptomatic, good performance status. Which of the following is true? Cytarabine docetaxel has limited activity in uterine leiomyosarcoma. Anthracycline combinations improve overall survival compared to single agent. Non-anthracycline combinations are as efficacious as anthracycline combinations, or none of the above. I hope by the end here you'll be able to answer each of these. So with that in mind, we'll talk about sarcomas. As you heard a couple of weeks ago, these are rare tumors. They're heterogeneous tumors. There's about 14,000 cases a year anticipated for this year. There's somewhere between 50 and 100 different subtypes. They're mesenchymal in origin, and they can occur anywhere in the body. We can think of them clinically in terms of those that originate in the soft tissues versus those that originate in the bones. We could also think of them from a molecular standpoint, those that are characterized by very unique chromosomal translocations and those that are characterized by karyotypic aneuploidy. And on most cancers which are organ-specific, sarcomas are more tissue-specific, and so they're named for the relevant normal tissue types that they seem to resemble, with some examples shown here. It's important to note that the most common sarcoma that we see, previously known as malignant fibrous histiocytoma, that term is now antiquated. It's now called undifferentiated pleomorphic sarcoma. It's the most common subtype that we see. Accounts for about 25% or so of cases. With respect to soft tissue sarcomas specifically, they account for about 1% of malignancies in adults. They're more common in our pediatric population, where they account for about 15%. And they account for the vast majority of sarcomas. So there's roughly 10,000 soft tissue sarcomas a year, or roughly 3,000 to 4,000 bone sarcomas a year. And if you look at all comers across all stages, the 5-year survival rate still is only 50%, which speaks to the fact that we need better therapies because most of our patients will die from disseminated disease. As I mentioned, sarcomas can occur anywhere in the body. About half of the diagnoses occur in the extremities, either in upper or lower extremities, 40% in the truncal region, half between the chest and half in the retroperitoneum, and then 10% in the head and neck region. And as I mentioned earlier, they're characterized by marked heterogeneity. These are some of the pathologic slides that you can see, just to point out that there's marked heterogeneity, and you really need a pathologist's expertise in bone and soft tissue sarcomas looking at this. So liposarcoma, shown here in the upper right, is characterized by lipoblast, and you may actually see fat globules. Depending on the degree of dedifferentiation, you may see none at all, so you really rely on IHC staining. Liposarcoma, shown here in the bottom left, is characterized by these cytoplasmic vacuoles, which may be a little bit hard to appreciate, but you can see them here, and that's typically a telltale sign for leiomyosarcoma. and GIST is shown up here, and then MFH, or undifferentiated pleomorphics, down here on the bottom right. When we talk about sarcomas, we need to talk about staging. This was talked about a couple of weeks ago, and I just want to point out a couple of things. We think about the tumor size. We think about we think about 5 centimeters as really being the cutoff between T1 and T2 lesions. We think of the tumor's relationship to the muscular fascia. If it's above the muscular fascia, largely in the subcutaneous fat, that's defined as a superficial lesion. If it's in muscle at all, then that by definition is deep. And also in sarcomas, we think about grade. So grade 1 tumors refer to low-grade tumors, 2 and 3 intermediate high. A year and a half ago, there was a change in our staging system. Lymph node involvement previously was characterized as being stage 4, but with some recent clinical trials that have been published, there's been a reevaluation of patient population, and they don't do as poorly as was initially thought. So now, lymph node involvement is characterized as stage 3, and everything kind of above this mark here and up is disease that can be treated with surgery, including aggressive lymph node dissection. And everything below here, basically stage 4 disease, is traditionally managed by chemotherapy. So we have several challenges, we have several limitations. Again, sarcomas are rare. There's genetic diversity, there's molecular diversity, there's heterogeneity, and it doesn't help the fact that our chemotherapy needs to be better. We have limited numbers of agents. We can probably count them on one hand, and the efficacy of the agents, again, is suboptimal. So we can think of them clinically in terms of origin from bone or soft tissue. We can also think of them in terms of molecular classifications, those that are characterized by unique chromosomal translocations and those that are more karyotypic chaotic. Unfortunately, the ones that you are most likely to see as an adult medical oncologist are the ones that are not characterized by the unique translocations. Those are things like Ewing sarcoma, alveolar rhabdomyosarcoma, myxoid and synovial sarcoma, whereas myosarcoma, liposarcoma, most liposarcomas and undifferentiated pleomorphic sarcomas are more characterized by aneuploidy. This is an example of just some of the potential translocations that you can see. I would point out one of the questions on your boards oftentimes involves showing you an X-ray of a bone lesion with kind of an onion-skinned appearance. You'll recognize that as Ewing sarcoma, but then it will ask you what the translocation is. And so you want to just remember that it's a translocation involving chromosome 22. But you can see here that there's a whole list of translocations, and the unfortunate aspect here is that these are still largely used for diagnostic purposes. The only entity on here currently where we've been able to impact the known chromosomal translocation with the disease type is here for DFSP. And that's characterized by taking the promoter region for collagen 1A1 and putting it upstream of the gene for PDGF. So in essence, what happens is there's overexpression of platelet-derived growth factor. And so imatinib, which is approved for DFSP, has activity against PDGFR. So that's really one of the few, if only, examples where knowing the translocation has actually been able to impact the treatment that we use. All these others are largely transcription factors.
Does crizotinib work in inflammation?
Yeah, so I was just about to say the other one, because I just saw it up there. So crizotinib, about 50% of inflammatory myofibroblastic tumors will actually have ALK, and there's one case report of 2 patients. One case series of 2 patients using crizotinib. That was actually published in New England Journal. So write up your case reports. Because sarcomas are rare and limited, NCCN, the first recommendation and an essential recommendation is that patients be managed in centers with expertise. And summarize Dr. Brigman's 30-minute talk last week. In the 1970s and 80s, amputation was the rule of thumb. In the 1980s, in the study by Rosenberg, we learned that limb-sparing surgery can be considered, and now limb-sparing surgery is the rule of thumb, with wide resection being the goal here, so a rim of normal tissue around the tumor. Okay? We've also learned from Dr. Larrier's talk last week that radiation therapy can be considered and should be considered for tumors that are high risk for recurrence. Those are typically large tumors, deep tumors, and high-grade tumors. And you can choose radiation therapy prior to surgery. You can choose radiation therapy after surgery. And these are some of the pros and cons. So in So we typically will do preoperative radiation therapy here. The field size is smaller because we can still see the tumor. The dose is smaller, but you essentially have a doubling of wound complications by giving radiation therapy before surgery. Okay? The reason why we're here is to really fully understand the potential role of chemotherapy. So I'm going to talk about chemotherapy as relates to limited stage disease, so again, stages 1, 2, and 3. I'm not going to really talk about neoadjuvant chemotherapy. The data is extremely limited. And then I'm going to transition into talking about chemotherapy in a metastatic setting. So for those of you who have been in clinic with me or who have come to some of the grand rounds before, you may have heard me say that, in my opinion, the use of chemotherapy for the adjuvant treatment of sarcoma is the most controversial question that we have in our field. We have been trying to answer this question for the last 20 years. Actually, I'm sorry, last 40 years. The first adjuvant trial was initiated in 1973. So for 40 years, we've been trying to show that there's a benefit for chemotherapy. And the fact that, as I'll show you, it's not kind of a category 1 recommendation just speaks to the fact that we haven't, in my opinion, definitively answered this. Some studies that you should know about. So this is called the SMAC, S-M-A-C, the SMAC meta-analysis. This was published in Lancet in 1997. 1,500 patients over 14 trials. And you can see the outcomes of interest that were looked at: relapse-free, overall survival, and then trying to identify subgroups. And these were trials that were looking at no adjuvant therapy versus some adjuvant therapy. And that adjuvant therapy really varied depending on the trial. All of the trials contained an anthracycline as the adjuvant chemotherapy, but some of them were anthracycline alone, in this case doxorubicin, and other studies were multi-agent chemotherapy, so a hodgepodge here. You can also see that the doses of the anthracycline varied significantly from as low as 50 milligrams per meter squared to 90 milligrams per meter squared. The standard dose that I will give is roughly 75 milligrams per meter squared. Okay? Here are your 14 trials. The first one here, you can see 1973, and the last one that was included ended in 1990. And in this study, they asked the question with respect to relapse-free overall survival, and overall survival, was chemotherapy better or not? So with respect to relapse-free survival, in the meta-analysis, it suggested that chemotherapy was better, as defined by the point estimate here, the summary statistic here, falling to the left of the center. It also showed that chemotherapy improved both local control, so preventing relapse at the site of where the primary was, and distant control, preventing the development of metastases here. But when they looked at overall survival, there was no significant benefit. Now, the optimists in the room would say that there's a trend. That's true, but the point is, at least from a statistical standpoint, it didn't reach statistical significance. Now, there were a lot of limitations to the meta-analysis. People said, well, there were wide ranges in doses of anthracycline used, and some of the combination regimens, the agents that were used had no activity, and so it goes on and on and on. So there were some inherent challenges with the meta-analysis, but this was the best data that we had. These are the curves shown here. Again, local relapse-free, distant relapse-free, and overall recurrence-free survival all were statistically significant. The overall survival benefit was not, and the absolute benefit was 4% at 10 years. So you treat 100 patients, 4 additional patients are alive at 10 years. You can decide amongst yourselves as to whether or not that's something that's meaningful or not. For most of the adjuvant trials that we have in breast cancer, or lung cancer, the benefit is somewhere between 8 and 15%, roughly. Okay, so I think if there is a benefit for chemotherapy in the adjuvant setting, it's small, it's marginal. Then they tried to identify subgroups of benefit, and there was a suggestion that males were a high-risk category, extremity sarcomas were high risk, high-grade tumors were high risk. And so the subsequent trials that came after this meta-analysis made an effort to try to enrich for those patient populations, so large, high-grade tumors. So between 2000 and 2005 or so, there were 4 randomized trials that were initiated. They're shown here, again, varying sizes, small trials to some that are a little bit larger. All used an anthracycline. Many of them, all used an anthracycline in combination with ifosfamide, which are the 2 most active chemotherapy agents we have. So again, we're trying to stack the deck here. We're taking high-risk tumors, we're using the best chemotherapy, and surely we're going to see a difference. But what you can see is that we don't. We may see some trends, but the bottom line is that for these 4 trials, None of them showed a statistically significant difference. So what do? Well, you make a second meta-analysis. And this was published in 2008. And this took the original 14 trials that were in the first meta-analysis, and it took the last 4 trials that I just showed you. So now we have 18 trials, about 1,900 patients, and we ask the same questions. And the summary here is that, again, local recurrence, distant recurrence were significant. Overall survival now reaches statistical significance. You can see that your hazard ratio is 0.77 with confidence intervals that do not overlap with 1. And I may have mentioned this before, but I was at the meeting when they presented this, and people actually stood up and clapped. It was a standing ovation. And then one of the senior medical oncologists from a peer institution stood up and said, I have 2 questions. The first question is, what was the methodology that you used for this meta-analysis? Was it the same as what was done originally? And the answer was no. So this was done using aggregate data. The original meta-analysis was done using patient individualized data, and so it's a less stringent way of doing things. And the second question that was asked was, did you use data from recent EORTC study 62931? And that was a study that was reported a year prior, which was the largest randomized trial ever performed for sarcoma, asking a question about adjuvant chemotherapy. You see it here. So a randomized trial of chemo versus no chemo with dox and IFOS. It was 350 patients. And in this study, there was absolutely no benefit in relapse-free survival, no benefit in overall survival. And so you can imagine if you take 350 patients and you add it to a meta-analysis of about 1,900 patients, it's probably going to account for a significant amount of weightage. So in my opinion, I think that the role for chemotherapy remains questionable. I think there is a potential benefit. It's not clear to me that we fully understand who the patients are. There's a suggestion that large, high-grade tumors are at greater risk, and that's typically who will be considered for adjuvant chemotherapy. But there are institutions around the country that firmly believe in it, and there are institutions around the country that don't. And at least currently, we fall on the line, because I'm the only one here, of not routinely recommending chemotherapy. I will talk with my patients about it. I've given it to one patient in the last 6 or 7 years because they wanted it. And that's fine. It's not the wrong thing to do. I just think, for me, a 4% absolute benefit at 10 years and data like this, it calls into question its usage. So what does NCCN say? So I had the benefit of sitting at the table when these conversations happen, and basically they don't happen. There's about 15 people around the table. We all get to this page. We all kind of look at each other. We look down, and we move on. So this is what we say. We say adjuvant chemotherapy can be considered, but it's got a Category 2B recommendation. What does that mean? It means that there's non-uniform consensus in the room. Okay. What do we say about neoadjuvant? The data is even less. And the bottom line is you can consider it. And I think, it's consideration. We typically fall on the line of pre-op RT, surgery, and then observation. Okay? What is clear, and what no one argues about, is the need for surveillance. And that's shown here. So we know that the risk of recurrence is not greatest in the first 6 months. It's actually in the first 2 to 3 years. And we also know that there can be late recurrences. So while it should go at least 5 years, it actually is lifelong surveillance. So as we go back to the questions, you'll see some of those. So what I tell people from the start is we're going to watch you very closely. We will watch you every 4 to 6 months for the first 2 years. I'll watch them every 6 months then for years 3, 4, and 5, and annually after that. For low-grade tumors, I'll start from 6 months from the beginning and do 6 months for 5 years. For high-grade tumors, I'll do 4 months for 2 years and then 6 months for years 3, 4, and 5, and annually after that. So surveillance is important. You need to image the chest. The lungs are the most common site of metastatic spread. And we don't come down hard and say X-ray or chest CT. So I'll oftentimes get a chest CT to start. If there's some nodules, I'll follow with CT. If there's some period of stability, then I'll transition to chest X-rays with maybe a CT scan annually. But you can really tailor that according to your practice. Okay? As I mentioned in the beginning, if you take all comers, 50 to 60%, the median survival at 5 years is only 50 to 60%, which means that patients develop metastatic disease. So the question then is, what is the role for chemotherapy for patients with metastatic disease? So for metastatic disease, we think of the chemotherapy options as those that are being Those are anthracycline-based and those that are non-anthracycline-based. And anthracycline-based regimens, we think of doxorubicin as being the workhorse, at least here in the United States, and it can be combined with ifosfamide, that's called AIM, the M is Mesna. It can be combined with dacarbazine, that's the D, AD. It can be combined with ifosfamide and dacarbazine, that's called MAID. That was the knee-jerk reaction probably in the 90s and early 2000s, and we've learned that dacarbazine probably doesn't add much but toxicity to the ADRA-IFOS, so for those of you who've been on 9300, if I do give a combination, I'll give AIM. So MAID is really fallen out of favor. And you have a series of non-anthracycline-based, some of which we've mentioned, IFOS and dacarbazine, but you also have gemcitabine-based regimens, gemdosi or gemnavalbine, and then more recently pazopanib. And this is basically our armamentarium. So again, you can count them on one hand. So we need better therapies. One of the questions that's been asked, just like there's a question in the adjuvant setting, the question in the metastatic setting is, should we give anthracycline by itself or should we give it in combination? And this was addressed in a meta-analysis of about 2,300 patients representing 8 trials looking at anthracycline versus combination therapy and then looking at response rates and mortality. And the bottom line is that there's a suggestion, a trend. Some studies show benefit more than others, but in general, combination is more likely to give response than single-agent therapy. Okay. It comes at the expense, however, of increased toxicity and no improvement in survival. All right. So I'm going to do this. So for me, my decision on whether or not to give a combination or a single agent depends on the burden of disease. It depends on the patient's performance status, and it depends on what I'm trying to do. If someone has metastatic disease but a fairly modest amount of disease and they're not symptomatic, I don't feel the need to give them dox and IFOS together. I'm killing 2 birds with 1 stone. Okay. The other thing I try to tell people from the start is that in terms of expectations, we are more likely to see disease stability than we are to see response. So disability is a good thing, and trying to lay that out for the patients in the start actually goes a long way, because when I didn't do that, they would come in and be upset that it didn't disappear, that it didn't shrink. So stability is the rule. Okay. Now, some have criticized that last meta-analysis, saying, well, the doses of doxorubicin were low. The things that they were combined with were not appropriate. So this was a study that was just published this past year that, again, used 2 most active agents, doxorubicin and ifosfamide, at good doses. These are the doses that we'd like to see be used in an adjuvant trial that haven't been done yet. But these are good doses of both of these agents in this case compared to doxorubicin. And it's for patients with locally advanced metastatic disease, and again, seeing which one does better. Large study of 455 patients, 2/3 of patients had metastatic disease. You can see some of the most common histologies there. And basically, what it told us kind of mirrored what was seen in the meta-analysis. First, combination seemed to have a better response than single agent alone. Secondly, at least in this study, there was no improvement in 1 or 2 year overall survival. There was a trend, but no statistically significant improvement. Progression-free survival was improved. Median overall survival was not. So we see time and time again, particularly in sarcomas, we see promising therapies with improvements in progression-free survival that don't pan out in overall survival. So my standpoint, I think that doxorubicin as a single agent can be considered a gold standard. I think combinations have the ability to improve response rates, improve progression-free survival, but again at the expense of increased toxicity and no statistically significant improvement in overall survival. And so this is what I do in my practice for patients, again, with low burden of disease who are asymptomatic, or if the patient has marginal performance status, I'm not going to give them dox-IFOS. I saw a patient last week, as a side note, a 77-year-old woman with metastatic disease, and the community physician gave her dox and IFOS, ADRA-IFOS. I don't give IFOS in my patients who are older than 65 because the rate of neurologic toxicities dramatically increases. She did horrible with it, and so she came to me saying, I'm never having chemotherapy again. So she is someone who I would have never given a combination to. So I give patients to people who have high volume disease, who are clearly symptomatic, and have a good performance status. Is that clear? So this is with respect to anthracycline. So what about our non-anthracycline based regimens? Most of our clinical trials have kind of had a lumping strategy. We've taken histologies and kind of lumped them together and given everyone the same thing, and then we try to make up for that on the back end by doing subgroup analyses of individual histologies and seeing which ones did better. There's emerging data to suggest that there are certain subtypes that seem to have preferential responsiveness to certain chemotherapies, and they're shown here. So Taxol and angiosarcomas, ifosfamide specifically in synovial sarcoma, gemdosi or dacarbazine, which is not listed here, in leiomyosarcomas. And so we're starting to tailor our therapies. And I wanted to talk just briefly about each of these. So paclitaxel was originally looked at in a phase 2 study in 1998 of 28 patients, an unselected patient population with soft tissue sarcoma. The response rate was 7%. And the conclusion from that study was that paclitaxel has no activity in sarcoma and shouldn't be explored further. 1 year later, there was a report that came out that was specifically looking at head and neck angiosarcomas and showed a response rate of 90%. Conclusion from that study is that paclitaxel should be further investigated in angiosarcoma. So then we had a phase 2 study, small phase 2, called the AngioTax study, which was published recently, which showed a more modest benefit, a response rate of about 20%. And this was not just head and neck angiosarcoma, but all angiosarcomas. And so now there's a general feeling that paclitaxel does have activity, but specifically in angiosarcomas. So for that particular histology, we will consider paclitaxel. We will never, ever have a randomized study looking at paclitaxel versus doxorubicin for angiosarcoma. There's only 500 cases a year. You'd have to recruit everyone in the country and still not have enough patients to show a meaningful benefit. So we, in a rare disease, rely a lot on phase 2 studies, so I will consider paclitaxel specifically in angiosarcoma. Gemcitabine docetaxel has been a regimen that's come into vogue in the last 4 or 5 years, and it's largely been driven by Marty Hensley and the gynecologic oncology group because it was shown to have activity in uterine leiomyosarcoma. These are 3 studies done in the GOG. The first actually was done in a broad range of leiomyosarcomas. The majority were uterine, showing a response rate of 50%. In the second setting, uterine specific, response rate of 27%. Again, this is after therapy. And in the first line setting, response rate of 35%. So that's very encouraging. So, between 30 and a 50% response rate in uterine leiomyosarcoma. So this was then looked in a open label phase 2 study called SARC-002 for patients with metastatic soft tissue sarcoma, all histologies. The primary endpoint was kind of a disease control rate. And what it showed was that the disease control rate, somewhat artificial because it also includes stable disease, but again, what I told you is my expectation for patients is that they have stable disease, so stable disease is a win. So disease control rate of 32% compared to 27% in gemcitabine. This just tells us that gemcitabine has activity, but the combination more so. The response rate is shown here, 16%. So again, modest, not the 30 to 50% that you see in uterine leiomyosarcoma, but a fairly modest response rate here. So very encouraging. So now gemcitabine and docetaxel will be used for a broad range of soft tissue sarcomas, typically in the second line setting after they've had an anthracycline, but will be considered in the front line setting if they have a uterine leiomyosarcoma based in part on the phase 2 studies. Again, recognizing that there's never been a comparison. Okay. So let's talk a little bit about what's new coming. Yep.
Are you talking about oligometastatic resection?
I can.
Oh, okay.
I wasn't going to.
Okay.
So Sandeep's question was about oligometastatic disease. So if a patient does develop metastatic disease and it's caught on surveillance and they have even if they have bilateral pulmonary nodules, if it's a finite number, we will be very aggressive with them and we'll do pulmonary metastectomies. And we'll go and we'll send them to the surgeon. They'll do one side, and then 1 month later they'll do another side. And oftentimes after that, I will put them back on surveillance. Some people will consider chemotherapy right after that. There is one study published from Memorial that looked at immediate chemotherapy after pulmonary metastectomy versus late, meaning until they recur again, and showed similar survival benefits. So I typically will put them back on surveillance because I've had some patients who go years again and then I have people who go a couple months. And if they go a couple months, I don't feel like I've lost any time. I now have something I can follow with chemotherapy, whereas before I'm just committing them to 4.5 months of chemotherapy with no visible disease. So I prefer to give chemotherapy when I have something to follow.
And aside from these specific instances, are there cases where you consider adjuvant based on chemoresponsiveness of the histology of the tumor as opposed to?
So some people do. Some people will say that myxoid liposarcoma is the most chemotherapy-sensitive tumor that we know of, and that's one that you should consider adjuvant chemotherapy for. My argument typically is, well, myxoid liposarcoma is also the most radiosensitive tumor that we know, and we've already considered radiation therapy. Angiosarcomas, I have considered some adjuvant chemotherapy in angiosarcomas because they're very aggressive and they'll spread along kind of the dermal interface, and despite getting a wide resection, they'll have literal just seedlings all around. It's kind of bad. So some people do, but for most of my patients, I don't. If they have local-only disease, I let the local therapy try and deal with it until the behavior tells me otherwise. Okay, so let's talk about what's new. So again, this is kind of our current armamentarium, both single-agent anthracycline and non-anthracycline regimens. There's also anthracycline combinations shown here. And you can see the response rates at best, maybe 20-25%. Survival rates at best, maybe a year, 18 months in the gemcitabine, although that seems a little bit long. And these are all phase 2 studies, so we clearly need new therapies. I mentioned how we typically like to lump. We're starting to get to a point now where we will split. We're starting to do histology-specific clinical trials. And so I'll talk a little bit about these. I'll talk a little bit about some novel cytotoxics, both in unselected and selected patient populations, and then talk about some novel therapies, targeted therapies in unselected patient populations, and then we'll finish up. So medicine that you may have heard about called palifosfamide. You've heard of ifosfamide. So palifosfamide is a newer version that's designed just to contain the active byproduct shown here. We're aware of the hemorrhagic cystitis, and we're aware of the neurologic side effects, the encephalopathy. Palifosfamide was designed to try to eliminate both of those toxicities. It doesn't require hospitalization, doesn't require neurologic follow-up, doesn't require following the urine. So this was explored in a phase 2 study a couple of years ago, shown here, a randomized phase 2 of doxorubicin at a standard dose compared to the combination. It did allow for crossover. And the primary endpoint was progression-free survival. In the phase 2, we saw a dramatic improvement in progression-free survival for the combination. So a very nice hazard ratio, statistically significant. And side effects were very similar between the two, with no GU or CNS side effects seen. So that's kind of the holy grail, being able to use a combination that improves survival outcomes but doesn't increase your toxicity, which is kind of the theme that we've seen in years past. So as a result, they moved this into a phase 3 study called the Picasso 3 study. The design is shown here. Patients were randomized in a 1-to-1 fashion to doxorubicin and placebo, or doxorubicin with palifosfamide. And they got 6 cycles with serial imaging in between, and then were placed on surveillance. The primary endpoint was overall survival, with progression-free survival as an accelerated endpoint. A large study of about 400 patients. It finished accrual back in December of 12. And they just made an announcement last week that the primary endpoint was not met, and so further development in sarcoma has been halted, which is unfortunate. So a promising phase 2 didn't pan out in a phase 3. TH302. TH302 is a hypoxia-activated prodrug. So many of our chemotherapies will kind of permeate the periphery of the tumor. The central core stays hypoxic. TH302 is designed to delve into the center of the tumor and hit that low oxygen, highly chemotherapy-resistant niche. And so in a phase 2 study, again, of dox in combination with TH302, we saw promising median overall survivals, promising response rates. This is now in a phase 3 that we have open here called the SARCO-2-1 clinical trial, very similar trial design to the Picasso 3. So dox, actually remove this placebo, it's open label, so there's no placebo. So it's dox versus dox TH302, maximum of 6 cycles, and then put on surveillance. The study up until a week ago was 450 patients, and the primary outcome was overall survival. And one of the major criticisms of this trial was that the magnitude of benefit that they were looking for was far too big, and that they shoot themselves in the foot. So they were looking for like a 30 or 40% improvement in survival. We've never seen that degree of improvement with any therapy. And so I think the point was finally heard, because just last week they announced that they were increasing from 450 to 620 to probably be able to identify a smaller difference. But this study is ongoing currently. We've put about 12 patients on the study. So keep a lookout for this. Those are two studies that are being looked at in combination with an anthracycline in a broad unselected patient population. So what about selected patient populations? So eribulin, you're familiar with eribulin. It's a microtubule inhibitor, non-taxane, and it showed very promising activity in sarcoma in a study from EORTC. The EORTC study is shown here. It was designed to look at 4 independent cohorts: lyos, lipos, synovials, and then others. So basically 4 individual phase 2s. And EORTC is fond of this outcome called the progression-free rate at 12 weeks. So basically a 3-month progression-free rate. Anything above 40% is thought to be beneficial. Anything less than 20% is activity, and anything in between is indeterminate. So in this case, liposarcoma was 32%, leiomyo was 47%, so they decided to move forward with eribulin in a phase 3, not in a broad population, but just in those 2 histologies. Okay? So we have that trial open here currently. This is the study from ASI, looking in the 3rd-line setting for lipo and leiomyosarcomas to either dacarbazine or eribulin, 1-to-1 randomization. That's ongoing currently. Again, a large trial, 450 patients, overall survival is the primary outcome. This actually just completed accrual in April, so we should have results in about a year.
They didn't test it to doxy.
Because I think that when this was coming through, you had the SARCO-3 study, you had the SARCO-2-1 study, and so the frontline setting is very crowded right now. They're looking for a different niche, which is actually pretty smart. Then you may have heard of trabectedin or Yondelis. It made a splash not too long ago in ovarian cancer, but it is derived from the marine sea squirt. It's a minor groove DNA binder. It's a DNA minor groove binder, and interestingly, it is approved in 26 countries around the world for the treatment of sarcoma. It is not approved in the U.S. Phase 2 study shown here, again, EORTC leading the way, showing some nice activity with some disease stability, nice time to progression of however long this is, 105 days. Nice progression-free rate at 12 weeks of over 50%. It has shown marked activity specifically in myxoid liposarcoma. So there are ongoing studies looking at myxoid liposarcoma with trabectedin, again, thought to be chemotherapy responsive, back to Sandeep's question. And then in a fairly large study published recently of 270 patients, specifically in lipo and leiomyosarcomas, again, very promising results. So the use of trabectedin has been a little bit of a challenge. Everyone believes that as activity, but the FDA says that they want a phase 3 study, which has not yet existed. So here it is. This actually mirrors the eribulin study design. It's a 3rd-line setting, lipo or leiomyosarcoma compared to dacarbazine. In this case, it's a 1-to-2 randomization. So the eribulin study just closed. We had that here, and now we're in the process of trying to open this up. So we are hopeful that this will show some activity so we can get trabectedin on the market. Our European, Australian, and Asian colleagues are all taking benefit of this medicine, but we have not been able to do so yet. Large study. And then I'm going to talk about 2 studies that you may have heard about before, looking at specifically targeted therapies in unselected patient populations. We look at there are a number of therapeutic targets being looked at in sarcoma. These should all look familiar to you because they're being looked at your disease states as well. Talk about mTOR. So ridofirolimus is an oral mTOR inhibitor. It was looked at in a phase 2 study as part of an IV formulation. The article was published last year, 212 patients. Didn't see many objective responses, but there was a very nice clinical benefit rate. So again, speaking to the fact that stable disease in sarcoma is important. Median overall survival of 40 weeks, which is encouraging. So based on the phase 2 study, which was in relapsed refractory sarcoma and an IV formulation, the company decided to use an oral formulation in a maintenance setting. So a different formulation and a different patient population. In this, they were smart in the sense that they were going for a niche that no one else was a part of. This would have been a home run if it was a positive study, or it could have been a complete disaster if it was a negative study. So here it is. It's for patients with sarcoma who received a defined course of chemotherapy and then are taken off chemotherapy and put on surveillance and are randomized to either a placebo or to the study drug. 711 patients. Primary outcome is progression-free survival with a number of other outcomes shown there. This is the curve that was shown at ASCO, and they highlighted the fact that they were dealing with a highly statistically significant improvement in progression-free survival with a nice hazard ratio. And everyone's excited until you get down to right here, and you look at the absolute benefit is 2.5 weeks. So it's a measure, the statistical robustness is more of a measure of the fact that it was a 700-patient trial. And then they did the survival curve, and they said that there was a trend. I'm not sure. The trend to the curves crossing each other. And I'm not sure there's much of another trend. So this was a big disappointment. And this to the ODAC committee in March of 2012, and they basically asked the committee, should this move forward to the FDA based on the data, and the people voted 13-1 against it. And they said that they were against it because in the maintenance setting, you need to have a bigger bar. What I breezed past here for the point of time is that 60% of patients require dose reductions due to toxicity. So there was significant toxicity, and there was limited clinical benefit. It wasn't statistically significant. Same day, at the same ODAC meeting, the pazopanib was shown. As I've already alluded to in the beginning, pazopanib is currently approved. So we'll talk about pazopanib currently. So pazopanib, again from the EORTC, in a phase 2 study shown here, showed promising activity based on a progression-free rate of 12 weeks being greater than 40%. We talked about that. And it was specifically looked at in leiomyos, synovial, and others. It was also looked at liposarcomas, but in the phase 2 study, liposarcomas did not show any benefit. So that goes back to one of the questions that I talked to you about. So the Palette study was performed. It's a phase 3 study, non-liposarcomas, non-GIST. Relapse refractory setting, randomized in a 2-to-1 fashion to either pazopanib or placebo. This study's primary outcome was progression-free survival, as shown here. So basically a tripling of improvement in progression-free survival, a 3-month improvement in progression-free survival, no improvement in overall survival, although there's an early separation and it didn't meet statistical significance, probably underpowered. But this study also went to the ODAC committee. It went to the ODAC committee in the afternoon. Actually, it went to the ODAC committee in the morning, got voted on, and then retiferolimus went in the afternoon. So in the morning, pazopanib comes up and they ask the question, based on the improvement in progression-free survival, based on the absence of improvement for overall survival, do they think it's worth moving on? And here they voted 11 for it and 2 against it. Those 4 said that it was a well-designed trial, blah, blah, blah. You can see the comments there. But importantly, FDA granted approval for pazopanib on April 26, 2012. That is the first agent that's been approved for sarcoma in 30 years. So it's kind of a tale of 2 drugs here, retiferolimus and pazopanib. So I'm in perfect timing. Summary slide. So chemotherapy for sarcoma, limited number of agents, limited efficacy. In my opinion, the use for chemotherapy in the adjuvant setting is controversial. If there's a benefit, it's marginal. I think you need to have the conversation with the patient and inform them of the risks as well as the potential benefits. It's clear that novel therapies are needed. There's a lot of work ongoing currently. We've already heard that phosphomide is a bust. TH302 is ongoing, as well as these other agents, particularly in histology-specific states. We've talked about pazopanib being the recent FDA approved, but importantly, I think that more trials are needed in individual patient populations because of the marked heterogeneity for this group of malignancies. So back to our questions. 50-year-old African-American man with a large, high-grade sarcoma of the right arm. He receives preoperative radiation therapy followed by surgical resection. Which of the following is true? Does chemotherapy consistently improve relapse-free survival? No. We studied the EORTC data, the largest study performed to date, which showed no benefit. I also did the data showing no improved survival. Recurrence is greatest in the first 6 months, typically in the first 2 to 3 years, and should surveillance be performed annually for 5 years? Well, yes, but then it needs to be lifelong, right? So lifelong. So the answer here is none of the above. When it was approved April of 2012, the efficacy of pazopanib has been demonstrated in all of the following histologies except sarcoma. And then what's the other one? GIST. Okay. Then 35-year-old woman with metastatic uterine leiomyosarcoma. She has metastatic disease with bilateral pulmonary nodules, is asymptomatic, and has a good performance status. So which of the following is true? Gemdosi has limited activity. Gemdosi actually has pretty significant activity, at least by response rate, for uterine leiomyosarcoma. Do anthracyclines and combinations improve overall survival compared to single-agent anthracyclines? No. Have non-anthracycline combinations been shown to be as efficacious as anthracycline combinations? We didn't really talk about this, but the answer is no. There's never been a comparison. The only trial that's ongoing currently is a trabectedin trial versus doxorubicin in the frontline setting. So that's the first kind of non-anthracycline combination. So the answer to this question is none of the above. This is my last slide. This is to tell you all that on April 27th, we will have our 5th annual Sarcoma 5K walk-run for our patients. It's over at the old ballpark, not the new ballpark. It starts about 7:30 in the morning. There will be dunking booth. I will be in the booth for about 20 to 30 minutes. So let's come out. Yeah, I think it's around 10 or 11, but come and dunk a doc. So with that, stop and ask if you have any questions. Clear as mud. So we didn't talk about GIST, we didn't talk about osteosarcoma or Ewing sarcoma. Those are all different entities. GIST, just remember that imatinib or Gleevec is the medicine that we use not only in the metastatic setting but also in the adjuvant setting. And then osteosarcoma and or Ewing sarcoma you will likely see on the boards because those are probably the 2 sarcomas which we can cure. And that's where chemotherapy really plays an important role in the initial treatment, unlike traditional soft tissue sarcomas. But I can give another lecture at a later date. Okay? Thank you, guys.